ourselves there. So direct savings from the supplemental rebates for fee for service was a little just shy of 21.6 million. And then federal rebates for fee for service was a little over 265 million. And then savings, so this is a new portion that we historically haven't provided because we now have the single PDL or the unified PDL. Savings associated with the managed care supplemental rebates is just a little over 139 million. And then their savings associated with the federal rebates was a little over 1 billion. So lots of money coming back to us on rebates there. And then estimated savings in fee for service alone for PAs for non-preferred agents, as well as those with drug specific criteria, was just shy of 20 million. So as far as our recommendations, continuing to review PA determinations and ensure that the criteria supports community standards and practice and evidence-based guidelines, making sure that we're making clinically and fiscally responsible drug therapy decisions. Continuing to utilize our point of sale quick check, which is our automated PA, to streamline the processing of those existing PAs. We'll continue to present new commercially available agents to the DUR board for expedited review, as we've been doing and will be doing today. We will continue to implement retrospective drug utilization reviews that are educational and will hopefully optimize prescribing practices and improve member care. And continue to utilize quantity limitations and step therapy to ensure appropriate utilization of our covered drugs. Continuing ongoing review of the PDL for any clinical or financial enhancements, if there's any classes we should add or take away. Continuing to look at age restrictions for mental health medications, as well as other safety edits that we can look through in there. We're continuing to address the overuse of opioids, benzos, sedative hypnotics, and gabapentinoids through PA. Continuing to collaborate with ONPP and the managed care entities for our statewide uniform PDL, and then looking at considering uniformity and PDL management for physician administered drugs that are currently dispensed via the medical benefit. Any questions or concerns on anything that you all saw or had in the PDL report?
Hey, Amanda, this is Chris. Is there an estimate that you have how much the PDL saves to total benefit cost?
So we have been looking at some of that. So if you look at just the rebate portion, we're looking at what, I mean, I can add that up and then the PA savings, but we don't have it. 1.6 1.6 billion is what?
Because I just had to do it legislative.
Okay. Because there's additional components to PA criteria on the managed care side that aren't included in the fee for service report. Any other questions? If not, if I could get a motion in a second before Mr. Johnson has to log off for a quick moment.
This is Chris, I approve.
Dr. Marshall.
Okay.
Have a motion in a second. Dr. Marshall.
Aye.
Ms. Pittman.
Aye.
Mr. Johnson.
Aye.
Dr.
Aye.
Dr. Treadwell.
Aye.
And Dr. Williams.
Aye.
All right, we have all ayes, so that motion will carry. So we are going to go back then in the agenda. I see, Chris, you need to jump off now. Yeah, okay.
Thank you.
So we'll look for you when you come back, and then we'll go back to some of our voting. So let's go back to the beginning here. Don't look. If you do, it'll give you a seizure or something. So, all right. So let's go back then. Dr. Marshall, any remarks of the chair this morning?
None.
All right. Ms. Lugo, OMPP, any opening comments?
None. Thank you.
All right. We will move then to the PA stats. So we do have a couple of months since we didn't have a quorum last month. So this was August 2024 PA stat approval. So we had 73% approved, 27% denied. You can see here the point of sale quick check and clinical call center. I'm not going to spend a ton of time on these just since we're talking about a previous month. And then here you can see the trending graph. Overall, we've kind of been going down a little bit over the summer months, which is kind of what we typically expect. But we have kind of seen this slight little decrease. It also could be partially related to having some of the pathways for aging group go out. We've seen just a slight decrease of our PA stats overall. And then stimulants, antipsychotics, opiates in the top 3 on the point of sale quick check side, and then early refills, MHKC utilization and anti-migraine, which tends to flip around sometimes with quantity limits on the manual PA side. So when we then look at other September stats, we had overall 74% approved, just shy of kind of 17,000, and then 26% denied, 26% denied at just shy of 6,000. When we look at our point of sale versus manual call center, so we have 77% approved point of sale, just shy of 14,000, and then a little over 4,000 denied at 23%. Of those that were denied, 20% went to the call center, where 80% were approved and 20% were denied. And then in the manual call center side, we have 53% approved and 47% denied. And when you look at our overall trending graph, again, overall fairly steady, still just a slight decrease that we've been seeing, but overall fairly steady from where we've been since kind of that July-ish time period. As far as top 10 PA requests for September, stimulants, opiates, and antipsychotics, again, we're in the top 3. Everything else fairly consistent on the point of sale quick check side. And then on the manual PA side, we had early refills, MHQC, and quantity limits this time that were in the top 3. Just kind of a little bit cyclical sometimes with how those shift around. Any questions on any of those before we go into the opioid stats? All right, hearing none. For our opioid stats for August, we did have a decrease from July on both the total opioid utilizers as well as the new utilizers. Our under 18 is pretty steady and hanging out around 4.56 days. You can see our less than 90 MMEs where the bulk of our patients sit. And then just a reminder, in the 500 and greater group, everybody's exempt, so we have nobody utilizing anymore in that group that's not exempt from having an exempt diagnosis. So here's the 90 and above trending, and then the overall trending, and I'll focus on this more when we get to the September report since this is August. And then you can see again, our less than 90 is really decreasing overall and continuing to decrease. And then everything else holding fairly steady here. We are seeing some increase there in the 200 to 250, which is kind of what we would expect since we've been decreasing some of those that are in the 500 group. So when we look at September, again, we found another decrease, not as substantial as we saw in August, but a little bit of decrease on the total utilizers as well as the new utilizers, around same numbers and exact same time frame for our under 18. Again, you can see in the graph on the right for our less than 90 being the bulk of the individuals and kind of everybody else where they fall out there. And so here's the graph for the 90 and above. Still have some folks that we've got to move through. We're at what, 425 now?
Yes.
Yes, 425, I think is about, right, yes. So we're at 425 MMEs, so we're still working through some of those folks that are in the 250 to 500 range. We're kind of working them down, but we are kind of slowly and steadily getting there. So you can see in our overall graph that we've kind of continued this, where we were continuing this increase for several months. We've now kind of continued this decrease, or this decrease over several months. I don't really have any clue as to what this is totally attributable to at this point. I think it's just something that we're seeing, and we're going to keep monitoring and see if we can figure out what's the current decrease about, but we have seen it kind of come down a little bit. And then our overall trending, the less than 90 again is down, and I really think the less than 90 is predominantly attributed to those individuals that either move off of our benefit into the managed care benefit, or those new starts going down. So as we see less new starts, because they're in the less than 90 range, we tend to see the less than 90 go down. And then again, looking at our kind of above 90 trending, fairly steady on most everything here, except this line does show a slight decrease from October, or from the August to September and down around the 250, 500, because again, we're working people down in there in the orange. Any questions on the opioid reporting before I go into the opiate overutilization provider review? This is for the 5 prescribers and more. All right. So this is our annual review around the opiate overutilization PA and the 5 or more prescribers. So just a reminder, since I know we don't do it super often, is we look at 60-day snapshots because that's where we're looking to see if anybody exceeds that 5 prescriber limit in each 60 days. Then comparing them to other 60-day periods to see how many people we have kind of hanging out there consistently overall. So this is just looking at each kind of 60-day snapshot. Really the important part here is we had 1 member with 5 or more prescribers, and then 3 in this next 60-day snapshot, and then 2 in this one. And then here's kind of a comparator graph where I feel like it's maybe a little bit easier to see, but basically the vast majority of our patients are in less than 3. We do have a few people that are in the 3 and the 4, and then very small numbers in the 5 or more. Again, a lot of times when we see people in the 3 or 4 group, it's because they are getting from prescribers that are in the same practice. So we're seeing nurse practitioners, et cetera, that are in kind of that same practice group. So nothing that's been super alarming there. When we look then at the comparison, so this is a comparison period between the first 60 days and then the second 60 days. You can see then that we had 2 that kind of hung out in that 5 or more space. But just a reminder, to get more than 5 or more, they do have to get a PA approved. So usually they're able to demonstrate why they're having that many prescribers at that point. This was the next 60-day snapshot, so the second and the third 60-day kind of look, and then again, only 1 in the 5 or more. And then this is kind of comparing the group as a whole, where only 1 individual remained in that 5 or more, and 14 in the 4. So any questions on that? At this point, our recommendation is the PA is still capturing what it needs to capture. We don't seem to have any inappropriate overuse of prescribers. Everything seems to be consistent with what we expect. Any questions or concerns on that? Do you all, the next question is, do you all want to continue to see this annually? We've shown it to you all annually and kind of you see the same data, but if you'd like to continue seeing it just to make sure it's still holding true, we're happy to provide it.
Okay, that sounds good. Keep up.
Thanks, Dr. Marshall.
Yeah, thank you, Amanda and everybody. I think this is really good data. I'm just trying to think how many years ago when we started this, what it looks like now compared to then. A huge change.
John's nodding. I think he's the only one here who's been here as long.
Anything preceded me was 2009 that we started implementing this process. So, yeah, it's been a while.
Very good. All right, well, thank you. So we do have a update on a retro-DUR that just finished, the DPP4 inhibitors and the GLP-1 receptor agonist concurrent therapy. Retrospective review follow-up. So at the 1-year completion, we did have 287 interventions that were identified as eligible for outcome, meaning individuals were using both a DPP4 and a GLP-1, which is not recommended, as we know. Only 5 of them decided to discontinue one of the agents, which was a planned savings of around $41,000. So we didn't get a lot of movement there, which is a little unfortunate. So it may be something that we are going to be looking at with OMPP on evaluating some PA criteria to more strongly guide people down a certain path. But at least we've gotten the news out there on kind of why that wouldn't be appropriate therapy, and we can move forward with looking at additional PA criteria. Any questions on that follow-up? The proposal and the topics and the PDL reports. We can now turn it over to the managed care updates. Who has the pleasure today?
Me, Monica. Can you hear me okay, Amanda?
Yes, we can.
Awesome. Awesome. Great. Thanks. Hi, everyone. My name is Monica Blankenship. I'm the pharmacy director for United Healthcare, but going to present on behalf of all the MCEs. I believe most of you are familiar with these slides, but for those who may not be, we have this slide, the normalized PAs per 1,000 member months on the left side for each of the plans within the HIP population. So those plans are listed there at the bottom, and then the corresponding approval percentages. Nothing to call out from the last 3 months of data that we added here. So next slide. So same graph here, but it's for the HCC population. So we have 3 plans within HCC, and you will see those there. Again, nothing to call out. And finally, HHW. Again, nothing really significant. So on this next slide, we have the normalized opioid claims per unit for our HIP population. Next slide is our HCC population. And then on this next slide, we have HHW, which is a little bit more variable than most of the other slides. And that's just because of the population with the kiddos. You'll see that the scales on both sides of the graph are much smaller than in the other populations, which is what we would expect. So nothing to call out there. And we do not have pathways for aging because we do present this on a little bit of a lag. So we'll have to add the pathways for aging in on our next update in another quarter. Any questions on these slides? Awesome. Thank you.
Thanks, Monica. You presented that so quickly. I don't think we've had time for Chris to get back, so we'll jump around in the schedule again. Just a little bit. So let's go on to any liaisons with other boards. All right, I'm hearing none there. Any other old or new business that anybody wants to talk about that doesn't require a vote, like my old new business? I can actually talk about my old business, I think. All right, so y'all might remember from a couple meetings ago, Dr. Klaus commented that other antidepressants are often used for, actually, that just reminded me, should we maybe take a moment to, because we missed the last meeting, I'm going to turn it over to Ms. Lugo just for a moment for Dr. Klaus.
I think hopefully everybody saw the email. I know Dr. Klass is trying to wind down his extracurricular activities at this point. So his last DUR board would have been last month, and we did not have a meeting. So Dr. Klass is no longer serving on the DUR board. That position is open at this time, but not that he'll hear this, but we want to thank him for his many, many years of service and great input to the DUR board. So
Yes, he will be missed. Speaking of that input, he commented that other antidepressants used in migraine prevention outside of tricyclic antidepressants were not included in the criteria. And so we originally had looked at kind of what was in the guidelines, what was in approved compendia, and then we would take that back for review. And so the guideline utilized is listed there. The agents chosen for step therapy trials are based on established efficacy defined as 2 or more class 1 trials based on American Academy of Neurology evidence classification. Agents must also have an FDA-approved indication or compendia support to be included. And so duloxetine is not compendia supported for migraine prophylaxis indication, even though it is in the guidelines. And then venlafaxine has compendia support for migraine prophylaxis, but is listed as second line and only deemed as probably effective per the guideline. So I did just want to let you all know that we are going to review this with the therapeutics committee and just kind of take a deeper dive and look at that to make sure we're including, but we did want to follow up regarding his comment that we have reviewed it. And again, appreciate his service on the board. Any questions or comments on that? All right. Let me check and make sure Mr. Johnson hasn't magically joined us. I don't see him. So let's then go to, you good with me doing public comment? No. Yeah, that's the only other thing I think about that doesn't require.
Well, you can go over the FYI stuff as well, like, I mean, public comments like now, but anything that's FYI, in other words, doesn't require a vote.
We got some vaccines, but other stuff requires a vote in it too, so it's probably just easier for me to.
Okay.
So let's do public comment. Get excited, get ready. So we have our new public comment, where you have to process, where you have to submit your request. So we did have 3 requests for public comment today. So we will start, and just kind of go down the list here. And we will start with Patrick Boland, or I think you are in the room, yes.
Yes,
So we will start with you.
sounds good. Are you ready for it?
I'm ready.
Great. So good morning. My name is Patrick Boland, and I'm a field HEOR scientist with Bristol Myers Squibb. I'm also a pharmacist by background and training. I'm here today to discuss Cobenfy, formerly known as KarXT, which was approved by the FDA on September 26, 2024, for the treatment of adults with schizophrenia. Cobenfy is a first-in-class orally administered combination of xanomeline, which is an M1 and fluoroporphyrin muscarinic receptor agonist, and trospium, which is a peripherally restricted muscarinic antagonist. Cobenfy is thought to function through a fundamentally different mechanism of action, modulating multiple neurotransmitters without directly blocking dopamine at the postsynaptic D2 receptor site. The efficacy and safety of Cobenfy was evaluated in adults with schizophrenia experiencing acute psychosis over 2 5-week inpatient randomized double-blind placebo-controlled trials known as the Emergent-2 and Emergent-3 trials. The primary endpoint was the change from baseline to week 5 in the positive and negative syndrome scale or PANSS total score. In each trial, Cobenfy showed a statistically significant and clinically meaningful improvement in the PANSS total score compared to placebo starting as early as week 2, continuing through week 5. Cobenfy is well tolerated, with common adverse events being primarily related to GI side effects. The adverse events were mild to moderate in nature, mostly transient, and discontinuation rates were comparable to placebo. The long-term safety and durability of Cobenfy was evaluated in the Emergent-4 rollover study, and was a 52-week extension study, including patients from Emergent-2 and Emergent-3. The safety profile during this year-long study was consistent with 5-week trials, primarily involving GI side effects. Cobenfy was associated with sustained and continued improvements and symptoms of schizophrenia over the course of a year, and the long-term utilization of Cobenfy was not associated with metabolic abnormalities or movement disorders. Cobenfy does not have a box warning, and in the label, there are no metabolic abnormalities or movement disorders. Thank you. Okay, thank you.
All right. Next on the list, we have Shirley Quach for Bethel.
Yes, can
Hello.
you hear me okay?
We can, yes.
Okay, perfect. Well, good morning, committee members. I'm Shirley Quach, pharmacist by training and a value evidence lead with Novartis. I just want to thank you for this opportunity to provide new information on Fabhalta or iptacopan. In August of this year, the FDA granted accelerated approval for Fabhalta, a first-in-class complement inhibitor for the reduction of proteinuria in adults with primary IgA nephropathy who are at risk of rapid disease progression. And this is generally defined as a urine protein to creatinine ratio, or UPCR, of greater than or equal to 1.5 gram per gram. Fabhalta specifically targets the alternative complement pathway of the immune system. When overly activated in the kidneys, the complement system is thought to contribute to the pathogenesis of IgA nephropathy. This indication is granted under accelerated approval based on the pre-specified interim analysis of the phase 3 APPLAUSE-IgAN study, measuring reduction in proteinuria at 9 months compared to placebo. The full approval of Fabhalta in IgAN will be contingent on the final analysis of APPLAUSE-IgAN, evaluating whether Fabhalta slows disease progression as measured by eGFR decline over 24 months. And the eGFR data is expected to be completed in 2025. Based on the study, Fabhalta demonstrated a favorable safety profile consistent with previously reported data, and Just to call out, Fabhalta may cause serious infections caused by encapsulated bacteria, and it's only available through REMS, where it requires specific vaccinations. And I think my time is almost up. So thank you for your time, and I'm happy to address any questions you have now or after the review of the class. Thank you.
Thank you. All right, and then last on the list, we have Daphne Nee for Spinraza.
Hello, could you hear me?
Yes, we can.
Okay. Hi, good morning. My name is Daphne Nee. I'm a medical liaison with Biogen. We'd like to ask that the committee consider revising the PA criteria for Spinraza to allow coverage of patients with 4 copies of SMN2 gene. And so just to recap, spinal muscular atrophy is a rare genetic neuromuscular disease. It's caused by a mutation in the SMN1 gene. However, patients do have a separate SMN2 gene that can partially compensate for the deficiency in SMN1 gene activity. Typically, the greater number of SMN2 copies a patient has, the milder the disease. However, we do know that the correlation is not always absolute. So for example, about 8% of patients with type 2 SMA have 4 SMN2 copies. These patients have symptom onset between 7 to 18 months old and may never stand. About 45% of patients with type 3 SMA have 4 SMN2 copies, and these patients have symptom onset after 18 months old and can walk but lose ability to walk over time. What's important to note is that expert consensus now recommends initiating treatment in these 4 copy patients. Prior to 2020, the consensus was to wait for these 4 copy patients, but in 2020, the consensus was revised to recommend immediate treatment for these patients. And the reason is because there are data that shows early treatment in pre-symptomatic patients leads to significantly better outcomes. So the panel felt that with early treatment, the disease would be mostly eradicated in pre-symptomatic patients with 4 copies. And also in May of this year, QRSMA published a set of recommendations in the American Academy of Neurology Clinical Practice Journal. And in that publication, they reiterated that the consensus by US SMA clinicians is to treat patients with 4 copies urgently. So that's our ask for the committee today, is to take a look at the PA criteria for Spinraza to bring it more aligned with clinical practice. Thank you.
Thank you. I don't see Mr. Johnson back yet. Everything else we have to cover needs a vote, so. Well, anybody have anything else they need to discuss today? Anybody have any fun weekend plans? He said he would be done like come back with some news on that. I guess so like. Just take a brief intermission here while we wait for his return.
If anybody knows of any positions that they can get to serve, that would be most helpful. I tried, but I can.
Do they need to be, just one of them need to be a psychiatrist?
No, I don't think so.
It think that's always been a preference, but I don't think it's.
I don't think so.
I could double
It's
check
4
that.
positions,
Yeah.
4 pharmacists. So I think he just take them.
Tell all your friends that the board is a cool place to be. Do you have
Geodes.
Hey, Leslie, I think it would probably be worth mentioning, right, that as we get ready for changes in administration and, legislation to go back in session, that we do expect it. And given the fiscal situation of the Indiana Medicaid program that is still under high scrutiny, that we do expect that there'll be a lot of Medicaid, bills that are trying to be passed, whether it's to increase funding for Medicaid or to restrict Medicaid further. So I think it's going to be a very interesting legislative session for us. And with the new governor coming in, I think we're probably going to be very busy doing a lot of bill reviews. And we're expecting a lot of them will, obviously impact pharmacy. Pharmacy and PBMs are always a topic of discussion during the legislation. So if some of you can't get a hold of Leslie, it's probably because she's doing bill reviews once legislation comes back in session. And I'm sure that many of you will be on top of those as well.
Objection. What you do. We played the balls. Oh, that's what. Yeah, we weren't in.
Yeah, it's just one position, so there's no specifications.
This was. I would almost, yeah. We don't have one for that one. That part of the Spanish. Good job. Our managing manager. The board. That she travels back with Virginia, along someday I'm gonna have to be my true player. Yeah. Probably. I'm married again. I don't like them. I've been to Ocean for thousands of. I know her family's like theirs, but she was, when the hurricane came through, because that would have been like the earliest one here in the world. It's not that she, it's Jamaica. She had family in the like in the mountains that were impacted. But everybody was. So whenever I see you in a headset, whenever I see you in a headset, I just picture you listening to like the transit. Yeah. Exactly. It's always like. She's just the private university. Yeah, you know, she's from the dietitian. So Sophia and I actually were really, this. It reminds me a lot of Butler and those in prep. It's kind of, yeah, but it's like isolated zone bubble. It has a really positive thing to it, and they're great. Sophia wants to go for a doctor. So, and they're really. She got accepted there and got a scholarship there, so she's looking at applying on her college and see what her scholarship is. Oh, is it? No, I mean, but we serve, like I said, but yeah, I mean, it's like, it's just a standard that they give out all the years for they automatically do it, like. Yeah. Yeah, it's free. Yeah.
That's my witness.
Yeah, I mean, she's very impressive. Mainly, you may work in a situation where whatever dad. Yeah. I think she likes you and each other, just really it's like how smells like lunch. She may still be like, how you and DC. Yeah, like you walk in and it's like. Yeah, it's like, just one more. I mean, it is like, she could go. So we get. Reach, realize that one year.
Yeah, that's what I mean, that's pretty clear. Think about his culture. Yeah, if you want. Bible.
So that's what it is. I don't know, I mean, but I'm trying not to like sway her at all. Yeah, I was her. No, where I went to school, so he really wants her to be right, he's wondering, she's like. It's not super, super. It's just your decision, like, and so she'll be like, what do you think I should do? I'm like, I want to tell you, like, I'll go to the person who keeps with you, like, we can talk about it, if we have members, I want to be like, this is where I think it's really things. Yeah, what I would do is different than what you would do, and I'm still paying up, my school and things over there. Like, but I enjoy my time, and I like this, it's beautiful, and I enjoy this, but. I barely pay attention to that, so. What did you say, I'll follow it? If they're better or practice?
I think it's about.
Right.
No, I know, but I think that's.
Something else. I was gonna say, like, if you would have told me there was this, then mom is federal. My parents still in Texas, so all of, even though I paid for my entire school, I didn't take out for anyone to guys. And nobody ever does anything with those, and it's like, as a kid, it's not like I had the money. And it's not like I'm here, it's just, it's not because I'm just like, here, let's make you and be wealthy or be ready. It's your selection. I mean, again, I'm stupid, I'm sure it's, school, I just don't think it would have been successful in this school. Still got some money.
That's.
Yes. Like even just. It's ridiculous, it's really not. Yeah. So. I mean, yeah, there's like some things that do like, boy, the men too, look forward to the heaven and forward to the making sure, especially when you can start it. And when your child is born in this, you walk into a tuition rate, and you know, when you start paying into it. Oh. Yeah, right. So then if you go in the state school, and they pay tuition. So some states are that way, that's nice, but. And then if they choose to go to like a non-state school, that way I can still go towards wherever they say. Okay. So it's not like it just. Okay. Like. Sorry. Just keep it in. And they have some deals where like I think even like. So it's just like Georgia, they get rid of Georgia, it's like some one nations, the deal with us. Been like a thing. Yeah. And it encourages people then to go to their.
Yeah,
Stay in state.
I know our
Right.
in-state attendance is terrible.
Here. Be a great way to get, encourage people to stay in state.
Yeah.
Yeah.
And much more reasonable. Like, look at the areas like we're going to start investing, X, Y, now over the course of 8 years and lock in this price and like.
Is it tax-free? I wonder. Oh, no.
I think that's just like a flight tax stuff because you're putting in, not like the safety bill, or the, what is that? They don't fight it and confident. Yeah.
Yeah, that's what we do. We just imagine.
Yeah.
I mean, it's.
Yeah.
Yeah, we don't know about it. It may be hard.
That's awesome.
So I think that's pretty good. And that should be much.
Because it's. It maybe get to the 6. Maybe. But it's.
Do they do how much that's?
So they have to get undergrad, goes to 3 years, right? Well, so it depends, because like 3 years before undergrad, then 3 to the grad school, so to speak, there. If you influence, you go to Minneapolis, for example, that has 2 programs, they do have a 3 and 3 where you get done at 6. But if you do the 3 and 3, you can't get direct admit, and they offer direct admit there. So if you do direct admit, which what's competitive, which was another advantage of other, like, as long as I knew that I maintained my GPS, I was okay, 17 minutes, right, you didn't have to do anything. Yeah. I can do it. There's a grade for that process. I didn't even like, I even have less of a chance of getting. Right.
We don't continue to take these valuable courses. I'm going to suggest I went for here, maybe if this is not online. I know that we have voting items to get done, but I don't know.
Can I make a suggestion?
This actually would be more TDR anyway, so.
Could we go ahead and go through all of the trucks, see if they have any suggestions? Obviously, we can't take a vote, but the office could still go ahead and put it in, knowing that they have no suggestions or objections.
That is correct.
And if Mr. Johnson shows up, then we just are running.
They didn't get those.
Right.
That's correct. Yeah, that's correct.
Dr. Marshall, unless you are opposed, I think since we still don't have Mr. Johnson yet, and he was supposed to be back by 11. What I think we're gonna try and do is go ahead and go through all of the new drugs and new business and just see if you all are okay with everything is there, or have any suggestions, or opposed to everything, or opposed to anything, but not take a vote, and then the office can at their discretion just go ahead and implement, even without the vote, knowing that you all have at least reviewed and, don't have any objections.
And then we would do a follow-up vote. We would have to do a follow-up with them next meeting.
Okay, that's fine, but I gotta leave here in the next, by like 11:20, 11:25.
Great, well, let's look through what we got then. So can we skip this medical benefit one?
Which one?
This
No, because I gotta get.
Okay, so we're gonna go through because. Sorry. So this is medical benefit only. The initial authorization is that the age is greater than or equal to 60 years and less than or equal to 85 years. diagnosis of Alzheimer's disease, and then you can see the testing there that they need to have met. And it is for mild cognitive impairment or mild dementias, consistent with the other agents. They need to have a baseline MRI of the brain that has been obtained within the past year that confirms the following parameters, and then those parameters are listed there for you. It needs to be prescribed by or in consultation with a neurologist, geriatric psychiatrist, or geriatrician. Oh, Mr. Johnson is back, so we can actually take a vote for this once we get there. Prescriber attests that the member's ApoE, E4 carrier status has been evaluated prior to initiating therapy, that they will not be using in combination with any other map for Alzheimer's disease, such as Aduhelm and Leqembi. The initial treatment dose is 700 milligrams every 4 weeks for 3 doses, and then maintenance treatment is 1,400 milligrams every 4 weeks. Exclusion criteria is any neurological or psychiatric condition that may be contributing to their cognitive therapy. And then we have the reauthorization criteria, which is history of the requested agent. The prescriber has provided updated documentation of clinical improvement or stabilization compared to the previous CDR, global score, or MMSE score. And then that they've provided updated brain MRI results, and then list that they have none of the abnormalities listed below. The dose is not exceeding the 1,400 milligrams. And then for continuation of therapy, they need to provide documentation of decreases in the amyloid beta plaque levels confirmed by the different measures that are listed there. These are performed at the 7th dose of medication at 12 months after initiating therapy, and then every 18 months thereafter. And then the prescriber states that the member remains a candidate for treatment, including that they have not developed any of the exclusionary criteria listed in the initial authorization. This is fairly consistent with the other agents that we have in place as well. Any questions or concerns on that?
And
we'll
were you
give this
supposed to
one-
be showing a screen? I'm sorry, maybe my view, but I didn't see anything.
It's showing on my screen. It's showing on others, so I don't.
Okay, must be me. Sorry.
You're fine. So we'll go on to the next new drug, just so we can go through all the new drugs at once. So we did hear about Cobenfy, a new product for schizophrenia. So for the initial authorization, it's going to be a diagnosis of schizophrenia with one of the following. The prescriber will be using Cobenfy as single agent antipsychotic therapy, or the member will be cross-tapering from a different antipsychotic agent to Cobenfy as a single agent therapy. And these are direct contraindications to Cobenfy use. And so the prescriber attests that the member does not have gastric retention, hepatic impairment, class B or C, untreated narrow angle glaucoma, or urinary retention. And they must meet the requested utilization edits, which I have, I believe, on the next slide. And then the reauthorization criteria is history of the agent in the 90 of the past 120. And then the same prescriber attests that the member hasn't developed any of the other following, and they're still getting utilization edits. Those utilization edits are.
Hold on, I'm going to add something to the reauthorization criteria. We do plan on anybody who has initiated therapy prior to the implementation of this PA that we're going to allow them to continue therapy.
Yes. All right, then for the utilization edits, so for the Cobenfy capsule, the 50 per 20, it's 2 per day, age 18 years and older, and then the 100 per 20 and 125 per 30 are all at 2 per day, age 18 years and older. And then there is a starter pack, that will be 1 pack for 90 days, and again, age 18 years and older. And then also in the new drugs, we have Bliss. And this is for atopic dermatitis, severe, moderate to severe atopic dermatitis. The member needs to be 12 years of age or older and weighs greater than or equal to 40 kilograms. And the prescriber attests that the disease is not adequately controlled with topical prescription therapies, or topical therapies are not advisable for the member. And then reauthorization criteria is going to look for history of the requested agent for 90 of the past 120. And then we have intravascular immunotherapy PA. So there's a new drug, adstiladrin or adstiladrin, however you want to pronounce it, updating PA criteria to prior history of at least 6 months of intravascular BCG therapy is confirmed by claims history, chart documentation, or provider attestation, including dates of trial. And then Anktiva is they need to be 18 years of age or older, a diagnosis of high-risk BCG unresponsive non-muscular invasive bladder cancer with carcinoma in situ, with or without papillary tumors, The member has prior history of at least 6 months of intravesical BCG monotherapy. And then they also need attestation that the member will use Anktiva in combination with intravesical BCG therapy. And if intravesical BCG therapy, and we'll start with that, is discontinued, the member will not use Anktiva as monotherapy. And then approvals will be granted for a max of 21 vials for the initial authorization. Reauthorization approval will be granted for up to 25 months. There is a lifetime maximum of 37 months. And they need to have history of the requested agent in the past 180 days as confirmed by claim history, chart documentation, et cetera. And the prescriber attests that the member will use Anktiva in combination with intravesical BCG as stated before, or if they're not, that they will discontinue therapy. And then those approvals for reauthorization will be a max of 15 vials for reauth and a lifetime maximum of 36 vials. And then for some non-SUPDL-PA and step therapy agents, Crexont, which is a new carbidopa-levodopa ER capsule, they need to have previous trial failure history of at least 90 days of therapy with generic carbidopa-levodopa extended release tablet formulation, or that they prescriber submitted valid medical justification for use of Crexont over the generic formulation, and the requested dose does not exceed 525 milligrams of carbidopa and 2,100 milligrams of levodopa per day. Reauth is history of the requested agent within the past 90 days, and then again, the same requested dosing. Ritari, again, another carbidopa-levodopa ER capsule product. We was just a real big rush on these past couple months. And so member has had previous basically the exact same thing that we just mentioned before, only replaced it with Ritari. So and the dose is different. So there are 612.5 milligrams of carbidopa and 2450 of levodopa. And then phenylketonuria, PA. So we have Cuban. The initial authorization is diagnosis of hyperphenylalaninemia due to tetrahydrobiopterin responsive phenylketonuria. Clicked on phonics worked for me all. Member is 1 month of age or older, and the prescriber attests that the member is confidently prescribed and will adhere to phenylalanine restricted diet. The member will only be using a single saproprotein agent, and member will not use any saproprotein agent with palynzic therapy, and dose requested does not exceed 20 milligrams per kilogram once daily. And reauth is history of the requested agent for 60 of the past 90. And then prescriber attests that they've been adherent to the diet. They're going to continue to only use single agent. They will not use with other saproprotein agents, and that their blood phenylalanine levels continue to remain lower than baseline. And again, the dose is 20 milligrams per kilogram daily. And yeah, okay, so palynzic is initial authorization is again diagnosis of phenylketonuria with uncontrolled blood phenylalanine concentrations greater than 600 micromoles per liter on existing treatment. And the member is 18 years of age or older, and then they need to have previous trial and failure of a saproprotein agent at an optimized dose of 20 milligrams per kilogram a day for at least 30 days in the past 60 days and supported by claims history or medical justification for use. The prescriber is attesting that they are enrolled in the REMS program and that they will not be using in combination with another saproprotein agent, and the dose will not exceed 20 milligrams once daily. The reauth criteria is requested agent for 90 of the past 120. And again, that they're still in the REMS program, they're not using with other agents, and that their blood phenylalanine levels continue to remain lower than baseline, and that the dose requested does not exceed 60 milligrams daily. That's the end of new drugs. Any questions? I know I literally just flew through all of those. If no questions or comments, if I could get a motion in a second.
So moved, Dr. Marshall.
This is Carol, second.
All right, we have a motion in a second. So Dr. Marshall.
Aye.
Ms. Pippin.
Aye.
Mr. Johnson.
Yes.
Dr. Hott.
Aye.
Dr. Treadwell.
Aye.
And Dr. Williams.
Aye.
All right, we have all ayes, so that motion will carry. We already went through our old business. Dr. Marshall, are you able to hang with me for new business? I'll be as quick as.
Okay, okay.
So for our amyloid beta directed antibodies PA for all agents, updating the duration of approval to 8 months. For Leqembi, updating the mini mental state examination score to greater than or equal to 22 and less than or equal to 30. And reauthorization criteria confirming amyloid beta plaque levels to the following at 18 months after initiating therapy. For complement inhibitor agents PA at Halta, we have updating drug-specific criteria to include newly approved indication with the following criteria, indication-specific criteria. So diagnosis of proteinuria associated with immunoglobulin A nephropathy confirmed by renal biopsy, and all of the following. So they need to have documentation supporting urine protein to creatinine ratio, and they need to have one of the following, and that the member has trial failure of at least 90 days of therapy with Filspari. The prescriber submitted valid medical justification for use of Fabhalta over Filspari, and the member has previous trial and failure of at least 90 days of therapy with maximally tolerated ACE or ARB agent, or that they have rationale for not using the ACE or ARB. And then they also need one of the following, that the member will continue adjunct ACE inhibitor or ARB agent therapy with Fabhalta, or have some justification for use of Fabhalta as single agent therapy. For the spinal muscular atrophy agents, PA, Evrysdi, and Spinraza, criteria clarification for those previously treated with Zolgensma. If member was previously treated with Zolgensma, prescriber must submit documentation illustrating evidence of decline post-Zolgensma treatment. In addition, a copy of a MedWatch report documenting Zolgensma treatment failure must be submitted to the FDA and to the plan. And then we have a link to the MedWatch form. For the targeted immunomodulators PA, Tofidence, updating the drug-specific criteria to include newly approved giant cell arteritis indication and maintain current status as non-preferred two-step therapy. For the thrombopoietin receptor agents, agonist agents PA, Alvea's initial authorization. So they must meet one of the following: a diagnosis of chronic immune thrombocytopenia, whose degree of thrombocytopenia and clinical condition increases the risk of bleeding. The member has had an insufficient response to corticosteroids, immunoglobulins, or splenectomy, and the member is at least 6 years of age and older. And then they need to have all of the following. They need to have a diagnosis of thrombocytopenia, members with chronic hepatitis C agents requiring initiation and or maintenance of interferon-based therapy. The prescriber attests that the member is currently on interferon-based therapy or will be initiated on it, or that the prescriber will discontinue therapy if the interferon-based therapy is terminated and the member is 18 years of age or older. And then they need to have a diagnosis of severe aplastic anemia. Member has had insufficient response to immunosuppressive therapies, and they're 18 years and older in that group. So they must meet one of those kind of following criteria subsets, and then within those subsets, they have to meet all of those things based on the diagnoses. And then reauthorization will be history of the requested agent for in the past 90 days, as confirmed by claims history, and then they submitted documentation supporting positive clinical response. And then Doptelet is again, kind of the same thing. We've got two criteria subsets. So one is diagnosis of chronic immune thrombocytopenia, and that they've had insufficient response to corticosteroids, immunoglobulins, or splenectomy, and that they're 18 years of age or older. Or they have the diagnosis of thrombocytopenia, they've had chronic liver disease and is scheduled to undergo a procedure, and they're 18 years of age or older. And again, that same kind of reauthorization criteria around 90 days of therapy. And or history of within the past 90 days, and that they've had documentation that the product is still providing a positive clinical response. Completa, they need to have a diagnosis of thrombocytopenia, they have chronic liver disease and scheduled to undergo a procedure, and they're 18 years of age or older. Nplate is diagnosis of hematopoietic syndrome of acute radiation syndrome. This is for a 30-day approval. And then they need to have a diagnosis of chronic or a diagnosis of chronic immune thrombocytopenia, whose degree of thrombocytopenia and clinical condition increases the risk of bleeding, and they've had an insufficient response to corticosteroids, immunoglobulins, splenectomy, et cetera, and that they're 1 year of age or older. And then the reauth again is history of the requested age within the past 80 days, and that they are having a positive clinical response. Promacta, again, we have 3 criteria sets. Very similar to what we've seen before for the chronic immune thrombocytopenia, they need to be 1 year of age or older. For the diagnosis of thrombocytopenia, members with chronic hep C requiring initiation or maintenance of interferon-based therapy, they need to continue the interferon-based therapy. If they aren't, they need to discontinue the promactin, they need to be 18 years of age or older. Or they have a diagnosis of severe aplastic anemia and the member is 2 years of age and older and will be using promactin in combination with standard immunosuppressive therapy, or that they are 18 years of age and older and will be using it as monotherapy and they've had an insufficient response to immunosuppressive therapy. Re-op is again looking for 90 days or looking for the agent within the past 90 days and that they have positive clinical response support. All right, now we're into a couple of FYIs. Ocrevus Zenovu subcutaneous formulation is added to preferred status with PA criteria matching Ocrevus intravenous formulations within the MSPA. Oxbryta was removed from the sickle cell agents PA and sickle cell agents PA form as it is being voluntarily withdrawn from the market. Preferred brand list updates that will begin on 11/1. Additions to the brand preferred list include Oxtellar XR tablets and Sprycel tablets, and then there are no removals. And then this is for implementation on 12/1. Additions include Sandostatin LAR 20 and 30 and Solu-Fortec 100 milligrams, and then removals are Amen Tritec and Traclear tablets. And then I think I'm on my last slide, vaccine updates for VFC and non-VFC pharmacies. Ervivo live vaccine at an age limit of 18 years and older and a quantity limit of 1 dose per lifetime. And then our COVID-19 2024-2025 vaccines, this is an FYI. I remember I started with Comirnaty, Spikevax, Moderna, and Pfizer vaccines updating the naming convention, but not one that I can pronounce clearly. And reimbursement for these vaccines to VFC and non-VFC pharmacies was retrograde to start on 8/22, which is when they were FDA approved. And then Novavax vaccine updated naming convention, and then the reimbursement again on, but this was for 8/30 when it received its FDA approval. I have included all of my new business. I see Mr. Johnson has a hand raised.
Hey, Amanda, just with, for example, the thrombopoietin receptor agonists, and that aren't those indications pretty much under specialist type care where like ITP or liver disease or something like that? Aren't those conditions all under a specialist type of care that the indications for use would be under that type of expertise? Is there a need, or is there a perspective information you're looking to gather for the PA requirements on this type of treatment?
So that we make sure we pay within the FDA approved label.
I'm sorry, I didn't hear that.
Ms. Lugo said so that we pay reimburse for these products within the FDA approved.
Do you believe there's a risk that they would be used off label?
There are always a risk that they'll use off something that pricey.
Oh, okay. Ms. Lugo said there's always a risk of potentially being used off label. So I know Dr. Marshall is needing to run here very quickly. So if there are no other questions, if I could get a motion in a second to approve these.
So moved.
This is Carol, second.
All right, we have a motion in a second. Dr. Marshall.
Aye.
Ms. Pippin.
Aye.
Mr. Johnson.
Yes.
Dr. Treadwell.
Aye.
And Dr. Williams.
Aye.
All right, we have all ayes. That motion will carry. Thank you so much for bearing with us and getting through the meeting. Dr. Marshall, that takes us to adjournment.
All right, adjourn. Thanks.
Thanks, everybody.